Okay, this is episode 71 of the Researching Happy podcast. As I explained last week, soon to be renamed the Wellbeing Explained podcast. And you can go and check out the conversation with Christian from last week to go and catch up with all the things that are happening at Be Wellco. Today is going to be a bit of a mystery episode because I don't know what to expect. I'm actually recording with two friends and colleagues, Associate Professor Hannah Wardill and soon to be Dr. Natalie Tuckey, who's a PhD candidate and a health psychologist. And so we've been working together really closely with a couple of other colleagues on a project that I've mentioned a lot of times on the podcast, but never in enough detail. And today is a chance to fix that, which is the delivery of our wellbeing intervention in a cancer population, which is people living with multiple myeloma. And so this is really, I think, going to cover a lot of ground. Hannah is, as I'll say, I'm going to embarrass her now, just a gun, just like so insanely successful at what she does. And I'm very happy for her, even though there might be some jealousy that you hear along the way. And so like basically she just leads the way in so many ways around supportive care, trying to improve the quality of life of people living with and beyond cancer, and knowing that there are so many unintended side effects that come with treatment. Hannah's really at that level, and just such a, I don't know if what you call like a rising star who's just not even at the beginning, just like continuing to rise. Equally, we're really lucky to have Nat Tuckey working with us. We actually used to work together at Be Wellco, and so Nat finished her health psychology degree and is now working out there in the world, as you'll hear, and has been, really instrumental in the modification of our program for this particular group and bringing it to life as well. So I hope you enjoy the episode. And yeah, a big aim of the podcast has been to talk about the wellbeing world, but actually from different perspectives. So we had lots of different people from different disciplines, not that much from medicine, basically. And I think nothing as applied and kind of as multidisciplinary as this project has been. So I really love to just basically talk about our experiences so far. We've worked really closely. Obviously, there's Mel and Katina and a couple of others who have been around the project with us. But I'd love to hear, maybe if we could just start with sort of who you are and what kind of work you're up to in the broader scheme of your life. So start with yourself, Hannah.
I am the lead of the Supportive Oncology Research Group here at Adelaide University in SAHMRI. And as the name suggests, or maybe it doesn't suggest, we do have a slight visibility issue in this field. Our goal is to improve the lived experience of cancer. So the way in which we aim to do that is by better understanding the side effects of cancer therapies, whether these be acute physical side effects like diarrhea, nausea, vomiting, whether these be long-term physical side effects like graft-versus-host disease, cognitive impairment, fibrosis, and other complications. These all fall under the umbrella of what we are interested in doing in the Supportive Oncology Research Group. I guess the foundation or the background to why we're interested in this, really for me, it came down to the fact that I realized that I really enjoyed oncology research. I wanted to be a cancer researcher, but I really wanted to have quite a patient-facing aspect of my work where I was driven primarily by the quality of life of people affected by cancer. So since meeting Nat and Matt, the agenda or the priorities of our group have certainly expanded to be more broad in terms of thinking about how these physical complications of cancer therapies also link into the mental health and well-being of patients. It's always been something that has been embedded in our program, but has kind of been considered this peripheral aspect, a secondary effect of controlling the physical side effects. And now we have this very specific well-being program that's built into the research group. And I'm really excited to have it.
Yeah, awesome. And Nat, yourself, the work that you do, and then maybe a bit of a summary of your PhD.
Sure. So the work that I do, so as a health and clinical psychologist, it's really about understanding the mental impacts of living with cancer. Being a survivor of cancer has some significant implications to someone's personal life, their family, their social structures, and I'm particularly interested in studying that connection to help improve how people understand themselves and how people can enjoy a better quality of life throughout their survivorship care. My PhD particularly is focused on multiple myeloma and the precursor form of smouldering myeloma. I was fortunate enough to be brought into the project at a point where it was kind of kicking off, which is amazing, where we got to know the consumers who are really sort of the driving force behind the initiative to this project, and really highlighting the unmet need of people with myeloma who are living with this disease for many years, which is a good thing, but also it affects them over a prolonged period of time. So the psychological impact of living with not just the side effects that Hannah's already outlined, but identity change, the change of treatment regime, the impact that has on your physical health and the ability to do the things that you used to love and want to do, but also the uncertainty that comes with living with an incurable cancer. So I'm particularly interested in supporting people in this space and doing what we can to improve their quality of life.
Well said. Very, very well said. All right, awesome. So maybe we should give a bit of a summary of what the project is. Hannah, if you want to have a go at that, because I think Nat and myself, we can just jump in and just pick up anything that we think, that may have come up along the way, because I think we're realizing there are maybe some unique parts. There are some parts of the project that aren't necessarily that unique, and some of the more unique aspects have actually sort of arisen along the way.
Yeah, so I mean, I can give some background context to why this project really came about. Essentially, it comes down to the fact that, as Nat alluded to, the condition multiple myeloma and its precursor forms, these are really challenging diagnoses to live with. So people with multiple myeloma, they typically undergo multiple rounds of different treatments. They are on treatment indefinitely. They're required to adhere to drug therapy essentially for the rest of their life to keep their disease under control. And what we know about many of the drugs that are used to treat multiple myeloma is that they're associated with many different side effects. So this, combined with the toll of living with an incurable cancer, combined with just the intense burden that it takes to adhere to these treatments, really does put these people in quite a challenging position in terms of their quality of life. So when we look across multiple different cancer types, we know that people with multiple myeloma have some of the lowest quality of life of all cancers. And so for us, that was a really pivotal piece of information to really hone in on people with multiple myeloma as a priority population within the Supportive Oncology Research Group. So broadly speaking, we have a very strong relationship with the multiple myeloma or the myeloma research laboratory here at Adelaide Uni. We've got a long-standing collaboration with them, really reflecting the fact that this patient population has very high supportive care needs. So we have projects looking at symptoms and side effects like peripheral neuropathy, so nerve injury from the chemotherapeutic agents that are used to treat these cancers. We have projects looking at microbial-based interventions, specifically fecal transplant in people with multiple myeloma to help with some of the gastrointestinal complications. And now we also have the MyWell project, which I'm sure Nat will explain much better than I will, which is specifically looking at building some mental health support for these people. So I guess, really the background to the project is that there's a clear unmet need for supporting people with multiple myeloma because of the many different facets of their treatment that make living with multiple myeloma very difficult, both from a physical and a non-physical standpoint. And this relationship that we've established between the multiple myeloma or the myeloma research laboratory and the Supportive Oncology Group has really demonstrated that when we work collaboratively together, we can start to unpick some of these really challenging problems. And I think the MyWell study is a perfect example of that.
Awesome. Yeah, Nat, you've been thrown under the bus there.
Yeah.
So I guess sort of going back to the intent of the project, which ultimately is to co-design a mental health program specifically for people with multiple myeloma and smouldering myeloma. And I think the real reason why we're sort of designing it specifically for this group is it is a rare cancer. So many people feel incredibly isolated, not being able to many people don't even know what multiple myeloma is. So in the community or even health professionals are having to sort of explain what it means and what it looks like. For many people, it's a it's an invisible disease because they might look well on the outside. So it's this real isolation that goes alongside having multiple myeloma and smoldering myeloma. So having this program where it's unique to them, they can it's really designed for this population. One of the unique aspects of the program is it's facilitated in a peer group setting. So people come together each week, they learn mental health strategies together, they go home, they practice, and they come back and reflect together. So there's that real peer connection, peer learning that's involved in this program, which I think is a very unique factor. So Matt, I don't know if you want me to go back to the beginning about how we're sort of adapting the Be Well plan, if that's what you'd like me to do.
Yeah.
Do.
Yeah, well, I mean, just broadly speaking, I guess there's sort of three aims to the project. The first was about taking an existing wellbeing skills program, something that Nat and I had been working on with others at Be Wellco for a number of years, mostly in the workplace, taking that and kind of road testing it in a participatory design. I don't think it was true co-design, as we found out from a recent peer reviewer. That's fine. But it was about getting this in front of people living in this particular context and hearing from them. Does it resonate? Is it valuable? Is it meeting a need? And what would you change about it? And so that was sort of the first aim, which we've ticked off. The second aim was then to take a modified version of this program, which Nat, you can jump into in a sec, and then running that through as a waitlist RCT, which we're almost at the end of. And then the third aim is about working with an organization called Health Translation SA, who will help basically design a what did we call it? Like a roadmap or a roadmap, or almost like a business case, basically, of why our partner Myeloma Australia, who we should mention in a second as well, why or how this could look for this to be something that's actually continually delivered in the future. So it's not just something that lives and dies on an RCT. The idea here, which I think is what I was trying to get to, of like something that's really unique, I think here is about having a nurse-led delivery of something that is clearly meeting a need within an established organization that's there to support, people living with myeloma.
I mean, you summarized that perfectly. That was beautiful.
Appreciate it. You'd hope so by now in the project, but yeah, I mean, it's also, I'm just thinking about Dom as well, like the idea of where did this project come from. So really worth celebrating, I think, particularly Mel Cantley and her team at the myeloma, is it the myeloma research group, right?
Yeah.
Is that what you called them, Hannah? Yeah, sorry.
Yeah, myeloma research lab.
So, yeah, sorry. Basically, they have this long-standing relationship with consumers. I think it's like been running for 10 or 15 years, where they do tours of the lab. They're always engaging them, and all the work that they do is like really incredible. And the fact that basically in one of those sessions, basically some consumers were saying like, the latest drugs and all these innovations, all amazing, but what we really need is mental health care and mental health support. And that was really led by a consumer named Dom. And who was even a co-author on the grant application. So really cool leadership in that space. I wonder where we go from here. Like, what do you think in terms of, do we want to talk, Nat, about the modification? But I'm thinking maybe about the gap, like particularly from what you've seen as a health psychologist, Nat, what do we think the gap is for this group of people in terms of care, and why does a group-based program change that?
Yeah, so I think I mean some of these barriers might be related to other cancers, I think, but obviously my research is in myeloma, so that's where I'll spend my time talking. But I guess in Australia, mental health support is tricky. It's tricky to access. There are difficulties in the referral pathways project. I was just at a meeting on Thursday hearing about the difficulties in being having a referral submitted into psychology and accepted, because they're really only got the capability, or the capacity, I should say, to manage acute mental health issues. So unless you're really at the pointy end, the psychological support for people is really limited. So and that's across mental health in Australia more broadly, I think, really, where we sort of only focus on people who are really distressed, and people that I've spoken to that I only really got help when I was kind of really crying or distressed, or people had to sort of report me, So there's this real stigma that goes alongside reaching out for help before it's really critical, I think. So I think there's some issues there about the services that we can offer people, I suppose, but also the personal stigma that goes alongside mental health. We know from a recent research that we did that most people want to keep their mental health concerns to themselves. They don't want to ask for help. It's hard to bring it up, even in a social setting. So there's a few barriers there for people with cancer. There are some supports, but generally they're very short term. And like I said, only when they're really in a crisis kind of mode. So there was a real opportunity here to create an intervention that supported people before they became significantly distressed. This is a program that we're designing for people who are looking at building strategies to help them manage the ups and downs rather than trying to reach them when they are at that low point. So, and having a group-based program like this allows for more scalability. It's online, so it can reach nationally, which takes some of the barriers out of this population who may have difficulty getting to appointments. They've got immune compromised or lots of difficulties traveling around the place. So there was a real opportunity there to create a program that was accessible and available before it became, needed at an acute phase, I suppose.
And
Yeah,
I think
awesome.
you've touched
Yeah,
on something really important there, Nat, that idea of preventing that escalation to a critical event. And that was something that Dom, the consumer advocate involved in the project initially, was really, really strong in coming forward to us with. He said, you have to have this base of resilience to live well with myeloma. And he often talked about this kind of cup half full, glass half empty type of analogy. And he said, you have to keep that cup half full, because otherwise you'll fall apart. And he would recount these experiences of his where he could feel his cup becoming empty and he could feel that spiral start to happen. I think what was really unique about Dom was that he had a huge amount of self-reflection. Like, his ability to reflect on his own situation was astronomical, and also his ability to document everything. He was a project manager. He documented extremely well, and so he was able to sort of track what triggered him to have these moments where the glass started to feel more empty. And he really came to us with that analogy and said, I know that I'm not psychologically unwell or at a point of crisis, but I can feel myself falling into that here and there. And so that concept was really critical, I think, for us to say, well, we need to find something that fills the gap for the vast majority of people with multiple myeloma who may not qualify for these intense clinical supports, but absolutely need something to help them ride through these ups and downs and to build these habits, to be more resilient in the face of these numerous co-occurring persistent challenges that they face. Mm-hmm. So I absolutely agree. I think that is the critical premise of this program. And that's why if and when Myeloma Australia take this program on board after the study is finished and we've generated all of the evidence needed for that successful implementation roadmap, this is something that really should be offered to every single person diagnosed with myeloma, irrespective of whether they are having a mental health crisis or not. It is something that they should all be offered. And so I think that that's the really important nuance of this program.
Yeah, and I wonder, so this has been, I talk about this experience quite a lot, of this idea of, when we sort of, Hannah, you and I were sort of walking around or going around to different places, kind of talking about this idea of, we want to test, this wellbeing intervention in supportive care, and kind of getting this feedback of like, oh no, we already do wellbeing. And so a lot of episodes of this podcast have been really about how do we define well-being and what does it look like in different settings. And I think it's been something so interesting to note, I guess, this challenge of well-being in those settings. Like, in many ways, they do focus on well-being. Their definition is just different to us. So what they're talking about was, I guess, really around sort of managing symptoms, trying to achieve some sort of physical activity, maybe getting back with, diet and managing side effects of treatment and things like that. we're obviously coming in with something quite different. And the one thing that I'd love to talk about now, and between whoever wants to jump on it, is thinking about the role of these amazing nurses that we've had the chance to work with, because something about this program, so that, I'll spoiler alert, I guess, this idea that the nurses have been so we're sort of 1.5 rounds into delivering the program for the primary group and now into the waitlist group. And they are experiencing, they've got such positive things to say about the program. The idea that this is meeting a gap, it is effective, and it's not anything like they've seen delivered in the past. So, one part of me thought they might just look at this at the end of it and go like, yeah, it's kind of more of the same of what we've done before. But the fact that they're kind of coming back with something, seeing this as something quite unique and valuable, I think is really heartening.
I totally agree. I think any form of oncology nurse is the unsung hero when it comes to supportive care. They are the ones on the front line, seeing the patients day in, day out in that chemotherapy suite, in that radiation oncology suite. We often forget the relevance of nurses. They are often more accessible, I think, for patients, or more approachable for patients to share their deep, dark vulnerabilities, particularly vulnerabilities that might be stigmatized or embarrassing or difficult to raise. The nurses are the ones that are there on the end of the phone, who will always pick up that phone and be there with really practical advice on how to manage their quality of life. So first things first, nurses in supportive care are absolutely critical. I think it also speaks to this broader challenge in supportive care, where we have a bit of a crisis in terms of whose responsibility is it. There's no formal qualification in supportive cancer care or supportive oncology like there is palliative care, for example. And so what this creates is a system of handballing of responsibility. And this means that supportive care often gets lost in the cracks of the very fragmented healthcare system that we all reside within. So I think what really is quite unique about the myeloma nurses is that they are specialist myeloma nurses. This is not something that every cancer type has. We know we have particular breast cancer nurses, but beyond those examples, there are very few cancer-specific nurses that are available. And so these nurses have the most in-depth understanding of all the nitty-gritty details of what it is to live with multiple myeloma. And that, to me, makes them the perfect group of people to deliver this program. But Nat, I'm sure you can add more to that.
I'll just add to that. Yeah, I'll just add to that. I think what it actually does for the participant is it instills such confidence in the content, in the program itself, because it's being delivered by such a trusted professional. I think, Hannah, you've mentioned these specialty nurses at Myeloma Australia are just gems. They honestly are. They know that not only do they have the intricate details about myeloma, the side effects and the, psychosocial issues that go alongside it, but they also have facilitation skills. They're already out there facilitating peer workshops and support groups where they understand, how to facilitate this kind of group-based conversations, I suppose. And from what I've heard from the participants so far is that they just absolutely love their facilitator. They believe everything they say. And what that does, it builds confidence that this is the right thing for them and that can really support them. Because I think, as a participant, you want to know that this program is going to work, and you feel hopeful that it's going to be able to, get a lot out of it. And I think it just instills so much trust and credibility into the program for the participant.
And worth mentioning that all of them are balancing roles. I don't know exactly what the split is, but whatever it is, half-time or a couple of days a week on the floor as a nurse, and then doing this balance. So they're right there on the edge, right? On the front line, I mean.
Absolutely. I think also
sorry.
Whoa, we've got so much to say about nurses. We love them. You go, Nat.
I was just going to add that anecdotally, they've also mentioned that this is a really good professional development opportunity for them as well, because it's kind of stretching them. They're outside their comfort zone and their normal sort of day-to-day learning about mental health. And I think there's a real benefit to them about being a facilitator as well, I'd like to add.
Yeah, that's a really good point. Yeah. The thing I was going to bring into the story as well is I think having them on board from the very beginning has also been a really unique, but more importantly, a really robust design decision, particularly from an implementation lens. You know, a lot of studies design something in the lab or in the research environment. You know, increasingly we're seeing consumer engagement, which is excellent, but that typically has quite a unidimensional perspective to it, where we think about consumers solely as the patients. But really, we need to think about consumers as stakeholders and a multidisciplinary stakeholder map of everyone who's going to be involved in the execution, delivery, rollout of whatever product is being developed. So to have Myeloma Australia on board from the get-go and involved in the co-design process has actually challenged us to look at the program with a slightly different lens, I think, as well. You know, they picked things up that we necessarily would not have identified as being critical components in terms of delivery and content. Yeah. And that, I think, has been really important in helping us develop and design a product that will be not only more meaningful for the end user, for the patients, for the people living with multiple myeloma, but also for its successful delivery. It means that these nurses, the Myeloma Australia specialist nurses, are embedded and invested from the get-go. And because they feel and they have been genuinely involved in the design of this new product, it just, again, it gives that confidence and that more seamless transition into the implementation phase. So it's been a hugely advantageous element of our approach, I think.
Yeah, agreed. And I think I've just got a note here for myself, which is, why has this felt so successful? And I think that's basically the heart of it, both from the consumer and from Myeloma Australia as partner lens. Like, I think we've talked about this a lot, the three of us, and with the wider team as well, particularly Katina, just can't believe how much this seems to be meeting a need. You know, and I think particularly from maybe some of our other experiences, whether that be trying to deliver wellbeing interventions in a workplace or in a university setting or whatever that might look like, that it's just so different. You know, this is a group of people who have felt left behind, and have this big gap, I guess, in what they're looking for, and this has come in at the right time to be useful. I'd be keen to hear from yourself, Nat, what you think in terms of, reflecting on some of our old days at Be Wellco, trying to deliver some of this stuff in universities or workplaces, and how it's been differently received.
I think the difference is that Australia is a trusted, reputable organisation who already offer supportive care services, really. And I think by adding this to their suite of products or opportunities for them to deliver something in addition to that, it's just the right fit, because, it's not going to fit within a hospital, in a private setting. It's different. I think having it in an organisation like Myeloma Australia, like I said, it's trusted, it's reputable. A lot of people already connected or know about Myeloma Australia, so the referral pathway seems a lot more straightforward. Mm-hmm. Whereas I think, in Be Well days, it was always like an external party coming in to deliver something, which seemed a little bit out of sync with the organisation, with the workplace, and, employees or what have you were then going, who is this and why are you delivering this, to me? Typical org psych things where people just come in out of nowhere. So I think, having Myeloma Australia as the organisation who's the front of it, I think just makes it seamless for the person with myeloma. And I think, as we often hear about disjointed services, I have to go to this person, then I have to go to this person. No one talks to each other. So I think having it in one place, and like I said, that they're often encouraged to go and connect with Myeloma Australia. Having it there just makes more sense, rather than a separate, isolated business that they haven't heard of before with a different name. I just think it makes a lot of sense.
I think also, the hematologists really believe in Myeloma Australia as well. I think that's something, and I'm sure, again, Nat, you can touch on this in some other parts of this discussion. We know that people with myeloma really value the advice that they receive from their hematologist. These hematologists are absolute up on the top of that pedestal when it comes to how they are seen from the perspective of their patients, and as they should be. Hematologists provide exceptional care. But what that means is that there's a huge amount of trust that goes into the relationship between the hematologist and the patient. And really, that patient does lean on the hematologist's advice hugely. And I think the fact that the hematology community within Australia is so trusting and connected and values what Myeloma Australia provides so thoroughly, we don't have to battle against that challenge. Like, we all know that we need a clinician champion in all of these types of services. And so to not have to fabricate that relationship between the service provider, aka Myeloma Australia, and the clinician is also a huge advantage that I think I'm really only starting to appreciate now.
Mm. Yeah, it's a little bit like, I guess, that feeling this appreciation to Mel's team. This, we've kind of got to piggyback on these decade or more of hard work building relationships. I think that can't be understated, and it's the same, I guess, between the hematologists and the good work of Myeloma Australia. In terms of things that have surprised you, so Hannah, this is your first go working in, well, I guess, outside of a lab, if I'm not mistaken. For myself and Nat, this is our first time working with, oh, actually, no, Nat, you've done it. For me, it's my first time working really in a clinical population. I'd love to hear, things that have been new for you, little friction points that might have come up along the way, and what have you sort of taken away so far from the project?
I mean, I've learnt a whole lot. I mean, I'm used to working with biological readouts that are quantitative, that are black and white, right, wrong, yes, no. And that generally is the type of person I am. I love statistics, I love maths because it's concrete. So I think for me, delving into the world of well-being was like really new. The subjectivity and the qualitative nature of it was a little bit daunting for me at the beginning, particularly from an analytical standpoint. I just didn't really know how to grasp it as much as I could, comparing it to another study that we're doing where our primary endpoint is the number of times someone goes to the toilet within 24 hours. That's a very hardcore endpoint. So I think, that sort of that subjectivity within well-being is something that I've had to definitely upskill in and become more confident and competent in navigating. But equally, it has, it's reinforced to me this interconnectedness of physical and mental health as well. Again, I appreciated the direction of physical symptom to making someone feel mentally unwell, but I didn't necessarily appreciate it in the reverse direction as well, and that influence that that certain well-being habits can have on the tolerability of a chronic physical disability, perhaps. And I think also I really didn't appreciate all of the nuanced layers of well-being and how well-being can look so different to an individual. The idea of empowerment versus resilience versus, I really just thought it was like anxiety, low to high, depression, low to high. I did not appreciate all of these beautiful nuances within wellbeing research. And I think starting to understand all of those and the different dimensions that make up the encompassing thing that is well-being that, we're still struggling to define, I think, has been really, really useful for me, thinking about it as this very complex entity, not just a quality of life score.
Mm-hmm. Yeah. Awesome. Thank you. And I'm going to come back to you in a sec, Hannah, just to talk about the immediacy of the impact that you get to see as well, because that's another thing we'll come back to. But for yourself, Hannah, Nat.
I've forgotten the question now, but what I was going to say was, I think for me, I'll talk about what I'm getting out of the project, but I think for me, I am the complete opposite, Hannah. I can't stand stats and I'm terrible at maths. And I love the consumer interaction. My favorite parts is meeting people, hearing their story. It is such a privilege to be able to hear someone's story and to listen to them as they're going through their struggles. And I think for me, what I'm learning the most, I suppose, out of this project is how myeloma affects people so differently, how people respond so differently. And I think that's the challenge with the project because, we're trying to create a group-based program that's kind of got flexibility, but also we kind of need to have some structure to it. And I think that creativity and that problem solving really comes to us as well about how do we help people navigate the ups and downs, use the strategies in a different way. We typically do a lot of mindful breathing, and then someone says, well, I've actually got a huge amount of pain in my chest, so breathing is not the right activity for me. It's a very simple example, but thinking about some of our activities that we would normally do in the general population don't necessarily copy over directly. So we need to be problem solving with the participants about how to help them utilize those strategies, which we know are evidence-based, but we need to sort of be more flexible with it. So I think for me, it's the well-being experience by people is so different and at different stages of their disease. And I think that's the hardest part with myeloma. You're constantly adapting to something different. It's whether it's a new drug or a side effect or no longer being able to do the things that you used to do. You're constantly adapting and changing, and that is so difficult, for everybody to be able to do on a consistent basis. So the same needs to go with the wellbeing strategies about how do you modify and change them accordingly each time you go through that change. So for me, I think that's the tricky part, I think, about this whole thing.
I totally agree, Nat.
Yeah.
Like the point you made, not only does that make it difficult in terms of how do we design this thing to be really meaningful for the community of people we are designing it with and for, but then also how do we make that fit into the fairly rigid constructs of what constitutes a high quality, rigorous clinical trial. That probably has actually been the biggest friction point for me, right? We want to create adaptability. We want to create flexibility in the endpoint so that the endpoint that is chosen, because all participants are going to have a different perspective of what they're hoping to achieve. What is the goal of participating in this program? And for someone that might be just being a little bit happier. For some people, it might be empowered to talk to their hematologist about a problem that they have felt nervous to bring up. It might be about having better relationships with their family. Maybe it's about giving them confidence to be more socially engaged. These are all really different endpoints that are equally meaningful to the different people that are reporting them. So then the question becomes, well, which one do you choose for that primary endpoint to say this trial has been a success? Whether we like it or not, that's these are the decisions that we have to make in designing a clinical trial to generate high quality evidence and to inform relevant clinical practice changes or to influence the field. And so I think that's been really quite challenging to navigate. Again, when we talk to the statisticians, they're even more rigid than I am. And it's been this kind of, I guess, a little bit of give and take with finding that sweet spot of, yes, deviating slightly from what a very conventional, drug-based trial would be to evaluating a flexible, adaptable, personalized wellbeing program under clinical trial conditions. And so I think we now probably recognize why wellbeing-based interventions maybe don't shine as much as they should within the conventional oncology literature, because it just is inherently difficult to match the rigorous clinical trial constraints with what is fundamentally central to wellbeing, which is that it's a highly individualized process. So that has been probably one of the biggest challenges and learning points for me.
Yeah, you're spot on. And I think I just came back from that conference in Dublin and, someone stood up basically as a keynote and said, the fact that we're still using RCTs is just ridiculous.
Yeah. What's the
basically
placebo?
we're adapting. Yeah, well, and we talked a lot about that. Like, how do you control for these things? But just, her opinion, which was Denise Quinlan, who's been on the podcast before, why are we taking something that was designed for, animal model testing or even like cell line testing, where you can literally control every variable and then apply that to as complicated as a system as a human being in an environment, and particularly in such a tumultuous context. So it's a funny one because we're kind of playing the game to some extent. Like, we need a randomized controlled trial to be able to wave around to show decision makers, like, this is a standard that you say is important, so here it is. whilst at the same time having enough flexibility and qualitative opportunities to collect that different data. And I'm thinking of from our pilot study, this experience of somebody basically saying, like, at a technical level, they kind of were someone that dropped out of the study, because they had something happen to them midway through the program. So if we look at it in a really black and white way, you go, okay, this program had no effect on that person. But when we hear from them and we conduct an interview later on or a focus group, you hear from them, they go, yeah, that was a really tough time, but I actually I used what I learned from the program. And it probably helped me bounce back. And it's like, well, that's the stuff that we miss.
Yeah.
We hear it, obviously, and we try and
people into numbers.
Yeah, exactly. So Denise will be loving to hear this. What to do about that, I'm not exactly sure. I don't know if you've got any guesses, but Nat, you've been like sort of on the front line. You said you like doing these interviews, and thank goodness for that, because you've done about I don't know, 30 interviews or something like that, maybe more actually, with clinicians and with participants in the program. Oh, it must be more actually. It must be like 40. Anyway, you can tell me. Like what have you heard, I guess? What are the things? Because you've interviewed like quite a diverse group of people as well. So I'd love to hear, what have you heard, particularly about like the gap that's out there, and maybe even how we're addressing that gap.
Put me on the spot, Matt. Let me think about so many things that people have told me. But I think, I guess going back to mental health and well-being, like I think some people are quite open to say that they've actually got some good well-being habits, but as we do find, if you think about your own well-being habits, they fall away when you get sick. They fall away when you're not feeling your best. So it's actually, many people are sort of coming to us and saying, oh, yeah, I've heard of that before, but I used to do that and I don't know what's happened, but I've stopped doing it now. So for some people, like, it's almost like they understand the concepts, but they know what makes them feel good. They've got plenty of life experience, about how to keep themselves happy and well. But when you get sick, when you're ill, consistently, you sort of, those habits really fall away. So I think what I've heard a lot from people is about wanting to sort of get back into those habits, or not sure how to do them because now they're physically unable to do the same things they used to do, for example. I've interviewed younger people with myeloma who are even a rarer group of people who have very different and unique needs than the typical population of myeloma, which I think the average age of diagnosis is around 70, 65 to 70. So anyone, below 50 is kind of even a rarer group, and they have different unique needs, who are still working, managing families, may not be able to have kids now because they've been diagnosed and on different sorts of treatments. So I don't know, Matt, you put me on the spot here in terms of all the different types of things I've heard along the way. I think it's important to mention the smouldering population. Smouldering myeloma is the precursor form where, correct me if I'm wrong, Hannah, but typically you don't get any actual treatment. You have to wait, just keep going back to your hematologist every few months to check your bloods to see if you then progress to myeloma. So you're in this waiting phase where you feel like you can't plan for the future. You don't have, you haven't got diagnosed with cancer yet, but you're not sure what to do. You're not sure if you should be making any decisions, buying a house, moving, making all these life decisions, because you're just waiting to see if it progresses. Meanwhile, your life's getting smaller and smaller because you're, terrified or paralyzed with anxiety. So there's just different things, I think, for people along the way. I think one thing in particular I heard a lot was about identity change, seeing yourself differently now that you have this disease, what it means for you and your family. You may now have a carer when you've never had a carer before, and that's a different thing to sort of experience, or no longer able to physically exercise. And that was a huge part of your life, to be able to be moving or what have you. One man spoke to me about how he was, he had just started retirement and how he felt that his life was opening up because he was just finally there. He's got all these savings and he had all these plans, and now his life is completely not what he was expecting, and that disappointment was just evident with what we were talking about. So bit of a bouncing around a little bit there, but I think importantly everyone's experience is different.
Yeah, and it's and I should just note as well, I'll probably say it in the intro as well, that I have given you no preparation. I've given you no questions for this conversation. So my bad. My apologies on that one. And you've answered them all perfectly so far. So I'm just throwing out anything that comes off the top of my head.
Could I pick up on something
go, Hannah.
You said in there, Nat? I think you touched on this concept of sort of losing contact with those habits. And that's something that we can all appreciate, right? Like, I know that I feel great about myself and I feel good when I'm going to the gym, but as soon as I get a little bit busy, it's really hard to like jump back into that. And I think that's where the peer group element of the program is really, really valuable. I think I haven't had the privilege of being in many of the actual sessions with the participants and with the consumers, but my take on it to this point is that the peer element, the peer connectivity, the shared experience, we all know that myeloma is very different based on individuals, but there are these commonalities in the lived experience of that disease. And I think that there's a huge benefit in recognizing that they're not alone, particularly in a rare cancer setting. So that ability to connect with people with similar lived experiences, I think, is really valuable. And I think hopefully our data does show that this is a component that does keep people coming back to the program. The friends that they make, I know that at the gym, I know that I think, oh, that person's going to notice that I'm not there. I told them last week that I'd be there at the session on Tuesday. So there is that almost that obligation to your peers in a session like this, which I think can be really positive. And it does bring me back to some of the earlier work that we did in breast cancer, where there was this suggestion that actually, having a gym buddy makes it so much easier to go with the gym, right? You go together, you reinforce each other's good habits. And we tried to evaluate that in the context of breast cancer, but we pretty quickly realized that women with breast cancer don't like to be too much of a burden on their immediate network. And so they actually had a preference of turning up alone, doing the program alone. And I feel like that was a big missed opportunity for us to understand how we could have supported those people better to feel confident enough to bring a loved one along, not as a carer or anything, but actually to do this activity together is something that they could build skills with together. And I do think we have brought that into the myeloma program a little bit. But I think that would be a really interesting next step to really understand, well, we've got this basis. Hopefully our data will show a base level of positivity, of improvement in mental health and well-being. But what can we do now to further enhance that? Is it so many different things, and that's what I'll be excited to be thinking about in terms of the implementation. It will not only be implementation and sustaining this program, but actually continually refining and optimizing and learning from all the people that participate in it to understand how it can continue to be refined and reflect the contemporary landscape of myeloma.
Awesome. Yeah, absolutely. And we've got sort of 10 minutes left. Now, I was actually mentioning this to somebody else. There's an entire, and I think it'll be a massive podcast. I haven't checked it out. There's a whole podcast show about death and well-being. You two went to a death festival. You're invited to present at a death festival. I actually realized I didn't hear too much about how that went, or what what went on there. So I'd love to hear. We've got kind of 10 minutes left. Tell me about this. And I'm thinking that if we could talk a little bit about the recent paper that we've had published, thinking about particularly some of those themes that you picked up, and being a burden was one of them, or the loneliness. Pretty a unique place to be thinking about well-being is at end of life. So yeah, tell me, how did the festival go, and maybe wrap in some of those perspectives from the paper.
Yeah, I mean, Hannah, do you want to?
I can make a start.
Go sure. Your take on things, and then I can wrap up with the paper if you like.
The Death Festival I thought was fabulous. It was all, as the name suggests, it was a festival all about death. It was, I guess, more so the structure of it was very much like an informal conference. So there was a trade display area. There were various death doulas and various services that can support end of life and ultimately death, which was really interesting just to navigate around. I thought death services were a fairly one-dimensional thing, but I learned that there are huge amounts of services out there. You can really die in many, many, many different, well, not die, but you can have your death commemorated in many different ways, which was enlightening and totally eye-opening. So we had a 1-hour session, which was really to share our experiences in beginning to build this program, and particularly leverage a lot of the work that Nat had done engaging with consumers and with carers, hematologists, nurses, to understand what it is to live with a terminal illness, what it is to live with your death sort of being almost dangled in front of your face, but not really having a strong sense of timeline of it. So we really recounted a lot of the learnings that Nat had through these interviews, and really just shared our approach to what we're hoping to do to better support people who are living with a terminal illness. We opened up for quite a lot of Q&A answers, and there were a lot of stories around how challenging it is for people to navigate death, or just to navigate a diagnosis of cancer, right? Even if it is a cancer diagnosis with a very high survival, for example, early stage breast cancer. My mum was diagnosed with that earlier this year. You still instantly think about your death, right? Even if you know the statistics actually say you've got an equal chance of dying to the general population, it's all you think about. So I think for me, it was really enlightening to hear all the different stories from people with various forms of cancer trying to navigate all of this. But I think a strong commonality was that they did seek some opportunity, or they really wanted some opportunity to talk about it, but just didn't know how to quite navigate their way there. And I think that this reflects some challenges, right? We know that as oncologists, as hematologists, your job is to be that positive light, to offer up treatments that will extend life. And from my interactions with hematologists, I know that there's a strong position of not wanting to show that they've given up hope. And so they keep going, they treat. I think there's some saying about hematologists, something along the lines of, maybe Nat, you've heard it and you can improve however I articulate this, but it's something along the lines of an oncologist would give maybe, the 5th line treatment and then refer to palliative care, whereas the hematologist would basically keep treating someone who's in a casket. And this is not a poor reflection on hematologists. This is that they've just got a huge amount of tools within their arsenal to treat these blood cancers, and they feel that they've got an obligation to try all of them for their patients. And they don't want to show that they've given up hope. They want to be that person who provides opportunity and options for their patients. But equally, they do find it difficult to raise the concept of death. And so this somewhat positions this conversation starter in the hands of the patient, and that in itself can also be an extremely challenging thing for people to do, to not only have that self-reflection that they're ready to talk about it, but then to raise it in a 15, 20-minute consult with their hematologist. So I think there's a huge amount of work that needs to be done in how those conversations are navigated, and helping clinicians pick up on subtle cues that patients may have. I know there's some work happening at the moment looking at how AI-based scribes can identify subtle cues in language that might suggest that a patient is sort of angling at this conversation. And I think that that's really where we're going to start to see really interesting innovation, because we know that early palliative care, when delivered effectively, improves the quality of that death, the experience of the patient, the experience of the family. It's just getting that referral is challenging sometimes. So sorry, I diverted a little bit away from the Death Festival, but I think it's such a fascinating concept.
No, it was a perfect segue over to you, Nat, particularly picking up on the want for this conversation. I think that's what we heard loud and clear.
Yeah. So in the interviews I did with participants, I didn't directly ask anything about end of life, whether that was intentional or not. Probably, again, goes back to that avoidance, right? So it was more about supportive care, and every single person brought up their existential crisis, because as Hannah mentioned, that's exactly what everyone goes through when they're diagnosed with cancer. But what also came through was this profound loneliness that goes alongside that, because nobody talks about it. Your family members, quite rightly, are like, "Oh no, you'll be fine, everything's good, don't talk about that, don't think about that sort of thing, like let's just focus on the positives." Your hematologist has only got 15 minutes, and I'll talk a bit more about, the avoidance that goes alongside that as well. So as a person, you're then left with this in your own mind about, well, what does it mean when when am I going to die? What should I do beforehand? So you're really sort of struggling with this on your own. Society doesn't like to talk about death. We don't have a great culture about how we embrace the end of life. It's very difficult. Most people are terrified of it, of course, not just about how you pass away, but the fact that you're leaving your loved ones behind and what does it mean for them and all that sort of thing. And then when we spoke to clinicians, and what I hear time and time again is this, that it's an icky conversation. Nobody wants to be the one to look someone in the eye with a really sad conversation. And hematologists will say, they look to you with these pleading, hopeful eyes, like, are you going to cure me? And then they don't want to be the one to upset them, or the family member doesn't want you to bring it up because you're going to upset the patient. And if the clinicians aren't bringing it up, if the family members aren't bringing it up, or having the space to be able to talk about it, then where does that leave the person who's going through this incredible, profound issue on their own? So I think there's a really, a sadness that goes alongside that. People have to navigate this whole thing on their own and keep their thoughts to themselves. And Hannah's been talking about early referral to palliative care, which I think is important, but I think it's sort of, we should also go beyond that before the point where we're at the end of a lot of hematologists will say, oh, I'll refer at the third line or the fourth line, as opposed to bringing it up early. And it's really about going back to the wellbeing, conversation. It's about, how do people want to spend their last 5-10 years of their life while they're feeling okay, rather than waiting to those last 12 months where you're physically unable to do the things that you wanted to do. Like, why not have those conversations early? So that way you can, have those final moments, conversations, plan for the future, plan for your family's future while you still can, I think. So I just think there's this missed opportunity, I suppose, to really, acknowledge it and have the space to be able to talk about it. Hence the paper that we just published, which really acknowledges the avoidance. Even I've been doing all this, adding all this work into like fear of recurrence and fear of progression, very, very common terms used in cancer, but they don't talk about death. We're fear of dying, not fear of the cancer coming back. Like, let's be honest about what it actually means. Even in our language, we are so avoidant about even acknowledging and talking about it. And I think what was really opening was the Death Festival was a bunch of people who were really there. They're ready to talk and think and express about how they're feeling. And it was just a really different space, I suppose, than where you normally hear and talk about death, I suppose.
Yeah, amazing. I just had to Google, is there a fear of death scale? And there is one, so we can look at that later. But amazing. So thank you both very much. Is there anything we haven't covered off? Anything you wanted to say that we didn't get a chance to? Otherwise, we can wrap up.
I reckon we covered everything. I think, we've gone from consumer involvement to unconventional trial designs fitting into trial rigid boxes. We've talked about death and all the beautiful things that can happen when we start to acknowledge that. I mean, I think we've done a great job of summarizing all the beautiful nuances of this project.
Awesome. Nat, yourself?
No, I don't think I've got anything further to add. I think, we've covered off on a lot of things. I think, I think there's a lot of room for wellbeing in supportive care for cancer. And I think, I'm excited to see where this project lands, and hopefully, permanently with Myeloma Australia to deliver this more broadly, because I'm excited to think that people will have an option throughout their cancer experience to be able to, talk about their mental health well and truly before it gets to the more difficult part. So, yeah.
Amazing. All right. Well, thank you both very much. Apologies again that I didn't send you any preparation at all. But that's kind of where my life's at the moment. So, yeah, thank you again.
No, all good. Thanks, Matt.
Thank you.
All right.